Welcome to AETCM, the emergency medicine channel. Shall we start,
Okay.
sir? A 20-year-old male came to ER with alleged history of snake bite with bite mark on his left foot 10 minutes back. On initial 10-second assessment, airway was patent, no pooling of secretions. Breathing respiratory rate was 20 breaths per minute. SpO2 was 100 on room air. Single breath count was done, which was 21. Coming to circulation, BP was 130/90, pulse rate was 113 per minute. Coming to disability, GCS was E4V5M6. In exposure, patient was febrile, but a bite mark on the outer aspect of left foot was seen.
What is the importance of a bite mark in a snake bite case?
To differentiate between dry and wet bite.
Bite mark. Importance.
Bite mark will be absent in krait.
Bite mark will be absent in non-poisonous bite. It can be very, very minimal in krait. Okay. In a severe bite like viper bite or adult viper, adult cobra, it will be heavy. That bite mark will be heavy. Okay. But can you treat a patient when you see a bite mark alone?
No, sir.
Okay. You must have clinical features.
But no swelling or no swelling surrounding the inflammatory changes was not seen surrounding the bite mark. Initially, we proceeded with whole blood clotting test. We have to take an empty vial or a test tube which is kept clean and sun-dried and take 2 ml of blood and wait for 20 minutes. Initial clot formation was seen when he came. Simultaneously, we had
So
sent...
what you do? So you take a test tube, we add blood 2 ml, you keep it for 20 minutes. And that shows clot, that doesn't show clot or
Clot
shows
or
clot.
clot.
Clot is formed. Next, what you do?
Then we'll have to recheck again after.
You have to again keep one more test tube. Okay. That is continuous testing. Okay. So if you have a PTNR, that can be done, that can be replaced. This test can be replaced by PTNR.
Okay, sir. So simultaneously we had sent PTNR and other lab investigation. Coming to sample history.
What is the advantage of PTNR over the whole blood clotting type?
For whole blood, at least more than 40% of the clotting factors should be absent. But INR is more sensitive and less than 10% to 20%.
Okay, so that early phase of the coagulation defects itself INR will be
elevated. Coming to sample history, a 20-year-old male came to ER with alleged history of snake bite near a railway track 10 minutes ago. According to the person accompanied by him, they saw a black-colored snake but could not identify the snake and could not bring a photograph.
Black poisonous snake, what it can be?
Why?
The thing is black only, but normally
it was dark and they couldn't see the color.
It is mostly vipers. Okay.
There is no history of drooping of eyelids, a blurring of vision, difficulty speaking or generalized weakness, no history of bleeding from gums, nose, no history of hematuria or hemoptysis, no history of ecchymosis or petechiae. Then our second WBC, whole blood clotting test, on the second time, clot was not formed, and we received an INR of 0.9. In 9, first sample
was
0.9.
Okay.
But second WBC was not clotting. So we had sent INR again and it was NCD.
Okay.
So
clot detected.
At the same time, patient had a BP drop from initially when he came it was 130/90 to 80/40. Query, we thought it was a vasovagal attack.
So, what are the reasons for BP drop in a snake bite?
Either it can be due to adrenal insufficiency or vasovagal.
You are telling what you told first was correct. It was vasovagal due to pain or anxiety, fear, whatever it is.
Then hemotoxicity, hypovolemic shock.
Hypovolemia can occur because of vascular leak.
Then some proteins contain cardiotoxins that can cause shock also. And already if patient is having underlying any disease like before he had some cardiac issues or MI, can again
tachycardia itself can produce hypertension in a non-cardiac disease. Last one is the adrenal insufficiency that occurs in viper bite. Okay.
Then we gave 2 pint of fluid resuscitation was done, and the BP came up to normal.
Okay.
So, then we took a consent and we initiated on anti-snake venom. Anti-snake venom, 1 vial consists of freeze-dried powder with 10 ml of NS, and we have to take 10 vials containing 100 ml, 2 ml per minute was given.
Okay.
No reactions were noted during. The transfusion.
Initial transfusion, suppose if there is a reaction, skin rashes or something, what you do?
Minute rashes.
Some rashes occurring during the transfusion. What you do?
So usually this anti-snake minute rashes is not.
Nothing. If you do, you can just continue the infusion. You can give Avil or something like that.
Only if you notice breathing difficulty or hypertension.
The patient develops hypertension, shock, or patient is having breathing difficulty, like
then
you
only
told,
we'll have to
you have to give
adrenaline.
Pre-treatment regimes. Are you aware about pre-treatment regimes?
Before
some doctors give, some guidelines are there, but not WHO guideline. Pre-treatment regimes are available. You can give subcutaneous adrenaline and you can give Avil injection. But how far it is going to work, we don't know. But some doctors prefer to give like that. Even without that, there is no requirement of pre-treatment regime. You can start ASV, 1 or 2 drops you can try. Then if there is no reaction, full dose can be given.
Then we had sent INR again. We have to send after every 6 hours because for the formation of new clotting factors it takes around.
So when you have a patient with snake bite, you have started ASV, you know that INR is NCD. Is it going to reverse with your ASV?
It can, if
it will not, because it is already damage has happened. So that damage will persist. You have to reverse it with some other drug. Okay. ASV is given for current circulating toxins. Okay. It can only neutralize the circulating toxins, which is already bound to the organs. It cannot be reversed. So that elevation of INR should be treated with separately with different drugs. Okay.
So we had made arrangement for 4 pint FFP.
Okay, now you know that the coagulation factors are nil or there is no production or destruction, and this is NCD, your INR is NCD. What is the next step you do? You do something.
Now we'll have to suspect DIC and we have to send
fibrinogen. How do you diagnose DIC?
We have to send fibrinogen and APTT. If elevation of APTT, decreased fibrinogen, so decreased platelets.
What is the fibrinogen level here?
Was 24, sir.
24.
Reduced.
Normal is above 150. So if it is less than 100 itself, you have to be very careful. Now it is only 24. Okay, so what do you do now? You have to continue the ASV. We'll discuss ASV. What else should have been done for the patient along with your ASV treatment?
Either we have to give FFP or cryoprecipitate.
Or that is not wrong. FFP or cryo means you give only neither of the one.
FFP contains all the clotting factors. Cryo contains specific 8, 13.
So you have to give both.
Both.
You have to give FFP 15 ml per kg
and cryo 15 units per kg.
So that has to be given along with your ASV. So both should be given because it's a DIC. Otherwise, what will happen is you are giving ASV, other side patient has already developed a severe coagulopathy. Patient can bleed either intracranially, in the eyes or in the abdomen. Somewhere he can bleed. Okay, so you have to be very careful.
So we had made arrangement for FFP, cryo and platelets and continuous 6 hourly monitoring of CBC, INR, fibrinogen, APTT.
What's the platelet level in this patient?
Initially when he came, platelet was 1,52,000. Then after 6 hours, it became 1,34,000. Now after After 6 hours again.
So some patients platelets also can drop. Okay. DIC, when the DIC occurs, platelet also can drop.
So the repeated INR again was NCD.
Okay.
So then we gave 20 more vials of injection ASV. Then after 6 hours.
So it is always better to transfuse continuously. Once you find out that patient is in DIC, then there is no point in waiting for ASV. You should have given it continuously. Okay, 30 vials you finish it off, because that is a maximum you can give. That maximum should be given first itself, because it is going to neutralize the circulating toxins. Once it is going gone and fixed to the organ, you cannot do anything with the ASV. So whatever you want to give it first itself.
So after that, when we repeated the INR, it came out to be 1.23. Then again we rechecked 1.20. Now it is 1.13.
So that has become normal. So basically, how do you manage a snake bite case outside hospital and inside hospital?
Outside hospital, we should do it right. We are not supposed to, like previously, which was done previously, now we are not supposed to tie a tight tourniquet or try the incision, incisor suction and also.
So now we have to. Instead of tourniquet, what you will apply?
First we'll have to immobilize or else we can put a slab and then just tie a
small cotton dressing bandage along with the skin superficially, so that the superficial spreading of the venom will not occur. You are not supposed to block the major vessels.
Yes. First we have to reassure the patient, then immobilize the limb, then we'll have to take the patient immediately to hospital. And
should we keep the limb above the heart or below the heart? Below. Or heart should be in the higher position. Should never be like some may place the limb in a upward, because edema will be there. Then try to keep the limb above the heart. That should not happen. Suppose you have a tourniquet, because we cannot educate everyone. Suppose you have a tourniquet, what you do when you get the patient inside?
If it is a very tight tourniquet, first we'll have to put a BP cuff above the tourniquet, then inflate above more than 10 mm of systolic blood pressure, then slowly release both.
So along with that ASV, you have to start ASV, then you release it. Why? Suppose you release it suddenly, what will happen?
Sudden gush of venom can happen. It can enter the central circulation and
it can produce sometimes hypertension shock. Okay, so to avoid that, you are putting a BP cuff above the tourniquet, slowly release it. Along with that, you give ASV.
Once the patient comes to hospital, first we'll have to look for the following factors to start ASV. If patient is having hypertension, fluid resuscitation has to be done. And
what are the red flags in snake bite?
If there is a patient is having hypertension,
so breathing from your red flag means it is a red flag for starting ASV. So what are the things you look for? Locally, what you will see?
It's a wet bite, so fang marks with the local swelling, inflammatory changes, and if we'll have to mark the swelling, and if the swelling is increasing size, then that's an indication. And if there is any tender lymph nodes, necrosis surrounding that, and if the patient is then systemic conditions like patient goes to hypertension, respiratory.
Before that, abdominal pain, that is very important. Many patients will have abdominal pain.
Abdominal cramping, diarrhea, vomiting will be present. Then hypertension, breathing difficulty or respiratory depression, there is decrease in single breath count, or a patient is having oliguria or rise in creatinine, renal failure, organ dysfunctions. If identified species.
Identify the species is very important or not?
It
is important to know, but if it is not most of the cases, it will not be available. So no need to try for that. If it is available, then it is well and good. You are only treating the clinical finding. You are not treating the snake. Okay. So is there a difference between small snake and large snake?
No, sir.
There is no difference. So only thing is, if there is clinical finding, then you treat the patient. Okay. Treatment is
anti-snake.
Anti-snake venom. All the snakes in our country, we have only polyvalent one type of anti-snake venom. Okay. Now cobra and krait. These are the two important different types of snake. Like now we are treating a krait bite. Sorry, viper bite. Cobra and krait are different from these vipers. How do they differ?
They are neurotoxic.
So how do you treat both of these things? How do you treat cobra bite other than ASV?
We can give neostigmine and atropine.
Atropine should be given, and neostigmine can be tried. In viper bite, krait bite. What is the difference? Neostigmine and this one will not work. What else will work? Calcium. Calcium gluconate can be tried. Okay, you can give atropine neostigmine in that also, but it may not work. You can give calcium gluconate, and some of the patients may go to ventilator. They may develop neurotoxicity because already this might have produced a damage in the neuromuscular junctions. Atropine neostigmine may work in some patients, like calcium gluconate may work in krait bite, but some patients will go to mechanical ventilation. Okay, you give ASV with mechanical ventilation. Okay. Then, what about compartment syndrome? This patient he developed compartment syndrome.
No, sir.
No. He had not developed.
Local swelling inflammatory was not there for this patient.
So some what is compartment syndrome?
If the pressure inside the...
Is it common in viper bite?
Yes, sir. Common
it is very common in viper bite. So how do they present?
Usually severe pain on passive movements.
Okay. So pain, more pain than the
clinical
symptoms. So that is very important. So you can, how do you manage that case?
Emergency fasciotomy.
Fasciotomy can be done. What are the long-term problems of snake bite? Long-term. Short-term is all these things what we discussed. Long-term?
It can cause arthritis.
Arthritis is not very common. What else is common?
In
viper bite only. It is very common in viper bite. It can produce pituitary bleed. Like you learned Sheehan syndrome.
Waterhouse.
Something like that. Okay. Waterhouse-Fredrickson syndrome is a bleed in the suprarenal gland. This is adrenal, pituitary gland. Okay. So what will be there? In males, what will be there? Female, what will be there? What is the clinical finding? They have all like hormone dysfunction. One of the major hormone dysfunction occurring in male is testosterone. So they have testosterone deficiencies. So some of these patients may require frequent testosterone loading. Okay, otherwise their growth will be stunted. Okay, so that can happen in viper bite. That's why this patient may require follow-up. If on follow-up, if they have weakness or something, we have to test the thyroid function, testosterone, everything. Since it's a male and viper bite, that has to be done. Okay. Can they develop the recurrent cellulitis afterwards, snake bite?
Sometimes, which is present in that re-envenomation can...
That is re-envenomation if it is like if you don't treat properly. But once the patient had snake bite by these vipers, there will be damage for your lymphatics. Okay. They have a chronic lymphedema like filariasis. Sometimes they can get recurrent infections. That is common. Otherwise, after many years, venom cannot come. That cellulitis can.
That proteins released from in the.
That is acute phase. Acute phase and within 1 or 2 days.
Yes. Okay.
After that, how long you can treat snake bite? How many days you have to treat snake bite with ASV? How many days you have to treat? How many days you can start the treatment? Is there a guideline for that? There is no such guidelines. But whatever treatment you want to give, like ASV, should be given immediately. But there are instances where the snake bite treatment has started even after 2 weeks. We don't know exactly these stories are right or not. But you have to, whatever you want to give, as an emergency doctor, whatever you want to give, you have to give immediately. Okay. So you assess the patient. If you feel that it's a severe envenomation, all the 30 wells should be given immediately. So there should not be any delay. So some doctors give TID dose of ASV. That is also wrong. Some doctors give heavy antibiotic for snake bite. That is also wrong. Should we give antibiotics?
Not for every case, if you're only suspecting.
Only if there is a local inflammation that may contain anaerobes. You have to cover anaerobic bacteria like crystalline penicillin, doxycycline, amoxicillin. That all can be done. But many snake bite cases may not require any antibiotic at all. Okay? Thank you.
Okay, sir. Thank you.